So welcome to today's webinar on post-COVID condition. The presentations will be delivered in English, but French captions will be posted in the recording afterwards. As we are gathered here today, we acknowledge we're on Treaty 2, 4, 5, 6, 8, and 10 territories and the homeland Métis. We respect that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. We pay our respect to the First Nations and Métis ancestors of this place and reaffirm our relationship with one another. To start with, we have two quick polls to learn more about who is in the audience today and your familiarity with today's topic. The first poll should be visible on your screen. Please select your role. So we're seeing a range of healthcare practitioners, and we're also seeing patients attending this call as well. So we have physicians, nurses, allied health professionals, and patients as well as public. We're going to have the second poll now, and it's to show the level of knowledge. And we're seeing that there is moderate knowledge for the value of testing, identification, and diagnosis. We're seeing a low to moderate for appropriate steps, and we're seeing low to moderate for guidelines as well. Thank you. This session is accredited, and following this webinar, you will receive the certificate and evaluation form. The recordings will be available after the series. Please post questions in the anonymous Q&A function or with your name visible in the chat. During the Q&A, you can also raise your hand and unmute. And these are the steps we have taken to mitigate potential sources of bias. Dr. Emilia Liana Falcone is an attending physician in the Infection Disease Department, director of the Post-COVID-19 Research Clinic, and Microbiome and Mustafa Defense Research Unit, and a Canada Research Chair and attending physicians. Dr. Reem Mustafa is an associate professor in nephrology and hypertension and director of the Evidence-Based Practice and Impact Center.
So I'm going to begin with the first portion of this presentation. Thank you very much for joining. It's a pleasure to be exchanging with you today on the testing, identification, and diagnosis of post-COVID-19 conditions. Here are our disclosures for myself and Dr. Mustafa. And so the objectives of today's presentation are to define post-COVID-19 condition, understand the risk factors commonly associated with PCC, describe common symptoms and conditions associated with PCC, and identify optimal evaluation and testing pathways for people with suspected PCC. So here are the panel members that worked on the development of these guidelines. So we have the guideline team members for the diagnosis of PCC. There's the guideline development group members, and of course, our wonderful evidence synthesis team. So as you may be aware, there are several definitions for PCC or post-COVID-19 condition. There's the WHO definition that came out in October of 2021. There was the CDC definition, and more recently, the definition from the national academies in the US. So for purposes of this guideline, the WHO definition was used. And I'll explain a little bit more what that is. So we're talking here about individuals with a history of probable or confirmed SARS-CoV-2 infection. And they're being evaluated at 3 months from the onset of the acute infection, either the diagnosis or onset of symptoms. The symptoms have to have lasted for at least 2 months and cannot be explained by another diagnosis. There are common symptoms that we see a lot, like fatigue, shortness of breath, cognitive dysfunction, and others. And with the main point is that there's an impact on everyday functioning. The other point to remember is that the symptoms can be new following an initial recovery, or they can be persisting from the initial acute illness. And of course, they can fluctuate or relapse over time. So not an easy diagnosis to make. Now, with the definition that came out recently from the national academies, they're largely the same foundation, but I wanted to point out a few interesting things. For one, it's that PCC is being referred to as an infection-associated chronic condition, because we know that some individuals are still having persistent symptoms years out. We also acknowledge that the acute infection may have been recognized or unrecognized. Some individuals could have been asymptomatic, and as we know, some had mild or severe symptoms in the acute phase, that is in those first 14 days after diagnosis or onset of symptoms. And again, we maintain the time point, which is really important. That again, for long COVID, we're talking about 3 months after the infection. So, what are the risk factors for developing PCC? So, from a clinical standpoint, we know that females are more at risk if the acute illness was severe. Also, if there's the presence of lots of comorbidities, and especially if patients had asthma or diabetes before, if they're smokers, if they had obesity, and there's some link with ethnic minorities and some socioeconomic deprivation. A lot of these risk factors do tie into having an acute illness that is very severe. And of course, we know, yes, that does increase your risk of having long COVID. However, let's keep in mind that the vast majority of people did not have a severe acute illness. And so if you look at the proportion of those people who have long COVID, these are really the individuals we're seeing most often in clinic. In terms of other risk factors that are more biological, so we're much more in the research realm here, but it is interesting. So there is a link with having a high plasma viral load of SARS-CoV-2, as well as EBV reactivation, although not clear if it's the infection that triggers the reactivation or if the reactivation happens before, and the presence of certain autoantibodies. So, what are the most common symptoms? There are these core symptoms we see a lot, such as fatigue, very common, shortness of breath, brain fog, pain, problems with sleep. So, this could include insomnia, but also hypersomnia. We have individuals that sleep sometimes 14 to 16 hours per 24-hour periods. And of course, post exertional malaise, which we're going to discuss more later on. That being said, these were some common symptoms, but we know that over 100 symptoms have been associated with long COVID. And again, here I'm just highlighting some of the ones we see this came out in this specific systematic review and meta-analysis. But again, we're seeing fatigue, trouble with memory, shortness of breath, sleep issues, and arthralgias. We also see myalgias as well. That being said, there are still these three profiles that we end up seeing in clinic, and it's kind of helpful to have these profiles in our mind when we're evaluating the patients because it speaks a little bit to the underlying pathogenesis of what's going on and maybe our index of suspicion for certain complications. So, what do I mean? We have those individuals who, in the acute phase of the infection, were in the ICU. And we know that no matter what reason you're in the ICU, there is a post-ICU syndrome. So that is something to consider. Then there's those individuals who had a severe acute infection. Usually they were hospitalized, right? They had O2 requirement, and often there'll be a diagnosed sequelae in this situation. So let's say they had a pulmonary embolism, or they had a heart attack or a stroke. And then there's individuals with less specific manifestations. Maybe they didn't have something that led to a positive diagnostic test that's been traditionally used in medicine. Nevertheless, they're having a lot of symptoms and they're really impacting their quality of life and functionality. And we see a lot of these patients in clinic. So the other thing to keep in mind, because it's relevant also for the guideline recommendations, are the sequelae that are highly associated with PCC. So these are not necessarily symptoms, they're actual complications for which we do have, in some cases, pharmacological interventions. So the first is pericarditis, perimyocarditis, so inflammation of the heart. Then there's cardiac dysautonomia. So here we mean either inappropriate sinus tachycardia or POTS, postural orthostatic tachycardia syndrome. We'll talk a little bit more about that later on. Again, we have post-exertional malaise, so we have to have that high index of suspicion to screen for it because it is highly associated with PCC. I'm naming here mastocyte activation syndrome, not necessarily because there's been clear evidence of objective diagnosis of mastocyte activation syndrome, but more because there's a lot of symptom overlap. So again, we see fatigue in these individuals, dysautonomia, GI distress, there could be muscle pains. The thing is that it is not easy to diagnose because you would need to have a serum tryptase measured typically in a flare. So not easy to get. So sometimes this diagnosis is made on clinical grounds. There can be overlap with long COVID. And sometimes if there is a suspicion of this can lead to treatment, for example, with antihistamines. So I wanted to mention that. And the other conditions highly associated with PCC are autoimmune conditions. We are seeing an increase in these in individuals who have been infected with SARS-CoV-2. So this is interesting, I think, and important to retain because it also speaks a little bit to underlying pathogenesis in the sense that we suspect strongly that there's an immune dysregulation underlying long COVID that may predispose to autoimmunity. So this may be evidence of this pathophysiological process. And here they are en français. And the other point I wanted to mention is there's been a series of studies that came out. A lot of them were based on the database from the Veterans Affairs Office with the US, the VA database. And what we see is these studies have reported significantly increased risk of either diabetes or metabolic conditions, cardiovascular diseases, renal disease, and neuropsychiatric illness, at least in the year following a SARS-CoV-2 infection. So this is something I consider, and it makes you wonder, how will this change how we screen for these diseases going forward now in this post-COVID era? And now I will pass it on to my colleague, Dr. Mustafa.
Thank you, Dr. Falcone. This was a great overview and background. Moving on, we're going to present a few slides about the methods we've used to develop these guidelines and the process we've used. And then we're going to go back to Dr. Falcone to go over specific recommendations, which I'm sure you're all looking forward to. So the first thing that we want you to be familiar with is this idea of a PICO, which means that we have specific questions that are structured as in what patients, what intervention, what comparison, and what outcomes, although they're diagnosis guideline, but we're very specific, trying to make sure that the data we're looking at informs the questions that are prioritized. So when we look at that, we actually start by having a lot of questions that were suggested in a very large brainstorming phase, where not only our panel, but we did get information from the larger PCC, CAN-PCC group and from the public. And then there was a prioritization survey, 2 prioritized questions that went ahead, which got us to our final list of 15 PICOs. Now, when we look at the questions, we are going to tell you what the questions we answered in these guidelines, and we had to categorize them. So Dr. Falcone nicely showed us that there are common symptoms and phenotypes that we see. So the first group of questions were in patients with cardiac or respiratory symptoms, and that is a long list, so we're going to go over it. So we have questions about in people with suspected PCC and who have respiratory or cardiac complaints. The first question was about, should we do an electrocardiogram, EKG versus not? The second question in that same population about doing Holter monitor versus not. The third was about doing echocardiogram versus not. And then we looked at troponin, specifically high sensitive troponin I versus not. And then we also looked at using BNP or NT-proBNP. Those are blood tests and biomarkers. This is the continuation of that list. We now also looked at doing a chest X-ray versus not, doing a chest CT scan versus not. And then we also looked at the ambulatory oximetry, so testing the oxygen when people are walking or moving. And we also did the pulmonary function test, or not. So these are all tests that we addressed in the people with suspected PCC and cardiopulmonary symptoms. Now we're going to move into another group of population, which are again suspected of having PCC, but who have fatigue or dizziness. And in these patients, we asked the important question about using a validated test or tool to assess their functional status. And we looked at many tools, but the one that was most commonly reported on is this Urquell 5D versus not using a tool. And the next question is, again, patients with suspected PCC who have dizziness, should we do a 10-minute standing test versus not to evaluate them? So now we talked about people suspected PCC cardiopulmonary symptoms with dizziness and fatigue. And now we have those who are suspected without any specific other entry point, if you may, that it is should questionnaires versus no questionnaires be used for post-exertional malaise, PEM, which we know is a pretty big problem. So we had to address that. We also talked about iron studies in general, and iron studies is a collection or a group of studies that can be ordered. We looked at a blood test called D-dimer, and we looked at another blood test called C-reactive protein. All of them are one way or the other, either have been reported to be at increase with this population, or that they could be associated with either a comorbidity or a specific complication. So that kind of concludes our list of questions. And once we had these questions, we started with the evidence synthesis, which means we looked in a very systematic way to evaluate the literature. And the way we did that is, this is the process of evidence synthesis about the benefits and harms. We also call them desirable and undesirable effects of doing the test. And it was not straightforward because there is not really available evidence that directly tell us, oh, if you do this test or not do it for these people, here's what happens. So we kind of had to include very indirect comparisons. So we were looking mainly at comparing patients with PCC who have the test done versus those who did not have the test done, but also maybe who do not have PCC, and put all this information together. You can think about it as trying to put together different puzzle pieces to make the picture clearer for us. And once we put all this information together, we had to evaluate what we call the certainty of evidence, meaning, do we truly believe that these results tell us the true impact of these tests? And in many instances, we were in the situation of having very low certainty. So we weren't certain at all. And the reason for that is because of all this indirectness that I mentioned to you, but also risk of bias. Some of the time, the people included in the studies were not representative of everybody who typically would have PCC. Also, many of these studies were quite small with very small number of people and really led to uncertainty. After now we did the systematic review, we collected that evidence, we evaluated our certainty, we had to, the panel had to go through a process. They have to make a decision now. So we call that evidence to decision, and we use a very specific framework with judgments. And in that framework, the deliberations they go through are presented on the next slide. So these deliberations are pretty extensive. They think about how important is this problem? What are the desirable effects? And they have to define what did we think? What did we believe the desirable or the benefits of doing the test? What are the undesirable effects? We had to explicitly discuss patients' values. And then we had to put all these four together and make a sense of the balance. What is the trade-off between all this? We also evaluated the certainty of evidence. Then we did consider cost and the certainty of evidence for cost, and if there were any studies for cost effectiveness, although in our case there were not. And then we also considered what are the impact of what we're doing and saying on equity, on feasibility, and on acceptability of these for the public. I must say, and we glanced through this, but our panel did include patient representatives, and our panel was quite diverse in the sense we had general practitioners, we had specialists, all were deliberating together and trying to make sense of all these decisions. Next, please. This is the same factors, but in French. When we came to make judgments about desirable effects, it was not easy. Because again, there's this lack of direct evidence. And what are we going to do? We didn't want to just say, oh, there is lack of evidence. We felt that everybody, our patients and colleagues who are treating those patients, actually are waiting for an answer from us. So we did develop this framework to make things very transparent and consistent between different recommendations. And we had the panel ask themselves the questions. Do the tests increase or decrease suspicion of PCC? The test helps diagnose or rule out an important comorbidity associated with PCC. Is the test help diagnose or rule out other important comorbidities? And does the test will lead to a change in patient clinical management? And once they answered these questions with yes or no, and of course deliberated on why they answered that, next please, then we came up with this criteria to say, we will say that the desirable effects are trivial if there is 0 or 1 questions answered as yes. It would be small if it's 2 to 3 answered as yes. It would be moderate if it's 4 answered as yes. And we will say that the desirable effects are large only when we have data that this impacted people important outcomes that patients and people with PCC care about. We did the same thing for undesirable effects. So we also had to make judgments and we had to come up with a framework. The framework for undesirable effect had less questions. And it was, the panel used this framework in which they considered the harms of the test directly and the risk of overdiagnosis. So those are the main questions. And then based on that, next please, the panel decided that it was trivial if the test did not cause any important harm or carry a risk of overdiagnosis, that it was small, undesirable effect if the test does not cause any important harm, but carries a risk of overdiagnosis that could potentially be mitigated, moderate, same as before, but that is not easy to mitigate, and then large, that when there is a true harm that the test carries, and the issue of overdiagnosis. So going through that framework, we did that for all our questions and then ended up with the recommendation. And now I want to explain to you a couple things. The first is when we say with the recommendation, we had the option of having strong or conditional recommendation. And what do they mean? And it was important to think about the implications from patients, physicians, and policymakers' perspective. Strong recommendations for patients mean that people will want to follow it, and a small proportion, I'm sorry, I lost the screen. And a small proportion of the patients would favor otherwise. However, a conditional recommendation does not have the same implication. Can we go to the English version, please? Thank you. For physicians, it means that a strong recommendation is that physician will want to prescribe it, and adherence could be used as a quality criterion. However, for conditional recommendation, it really means that most physicians will want to prescribe it. However, that this is an important recommendation to have considerable shared decision-making with your patients, explain what is happening. You might need decision aids to help with the recommendation and so on. And for policymakers, strong recommendations, they will want to be adapted directly, mostly as performance indicator, while again, conditional, they're not ready for that and they require quite a bit of discussion. So now that we know how we develop the recommendation, what are the options for these recommendations? Next, please, which will explain everything in French. And moving forward, I believe Dr. Falcone is going to take us over the actual recommendations, some of them. Thank you very much.
Thank you so much, Dr. Mustafa, for that great explanation of what leads us to these recommendations. So we'll get into the presentation of the recommendations that have been published, and there's going to be towards the end recommendations that have been shown to the public for public feedback, but of course are still not finalized and therefore may change over time. So we'll get to those in due time. So the first recommendation is the one on performing an ECG. So we know that, again, the target population here are individuals with suspected PCC and cardiac or respiratory symptoms. And we know that these symptoms are common in individuals with PCC. So, using all the framework that Dr. Mustafa explained to you with lots of discussion, this led us to finally a recommendation suggesting the use of ECG versus not using it in individuals with suspected PCC and cardiopulmonary symptoms. This is, of course, a conditional recommendation based on the very low certainty of the evidence. So the next recommendation is the one for the Holter monitor. So some of you know that using a Holter monitor involves continuous recording of ECG data, and this can be through variable periods of time. So it can be 24, it can be 48 hours, sometimes even longer. For purposes of this recommendation, we looked at the 24-hour Holter monitor. And of course, this could be useful to track continuously heart rate, rhythm, and help diagnose cardiac arrhythmias. And so in this sense, it could be helpful in the context of individuals with suspected PCC. So our final recommendation here was the CAN-PCC collaborative did suggest using Holter monitoring versus not using it in adults with suspected PCC and certain cardiopulmonary symptoms. Again, this is a conditional recommendation with very low certainty of evidence, and the cardiopulmonary symptoms specifically that we're referring to are chest pain, dyspnea, palpitations, tachycardia, bradycardia, that can be sustained or intermittent or of short duration. Next is the recommendation for BNP. So as we've already discussed, we know that a lot of individuals with PCC have cardiac respiratory symptoms like chest pain, shortness of breath, and cough. And this test can be useful when combined with other tests to help evaluate for acute coronary syndrome, pericarditis, myocarditis, heart failure. And so there's thresholds according to sex. And of course, whether if we're using the normal BNP or the anti-pro-BNP, and of course, these cutoffs, will also depend on your local laboratory. And the recommendation here is to use the BNP in adults with suspected PCC and cardiac or respiratory symptoms. But again, these tests, so far as you can glean, do not help diagnose, or they will not specifically diagnose PCC, but rather they're to help you diagnose or rule out other important comorbidities. So the next test is the troponin, or high sensitivity troponin. So as many of you know, when there's myocardial damage, this can be detected in the blood by measuring the troponin. There are different troponin tests available. The one that was favored was the troponin I over the troponin T, because it's more likely to detect an abnormal result. Again, the cutoffs vary by sex. But generally, if there's a high sensitivity troponin, highly sensitive troponin I value over 100 for males and over 75 for females can increase the likelihood of there being myocardial damage. So here, the CAN-PCC collaborative suggested for the use of troponin I, or high sensitivity troponin I tests in adults with suspected PCC and cardiac or pulmonary symptoms. Again, it's a conditional recommendation based on very low certainty of evidence. Next is the 10-minute standing test. So if you recall earlier on, we discussed that this cardiac dysautonomia, and specifically POTS, or postural orthostatic tachycardia syndrome, have tended to be highly associated with PCC. And so with that, this is an interesting test that can help us diagnose cardiac dysautonomia. And here, we're talking specifically of a heart rate, at least that's higher than 100 beats per minute at rest, and can be accompanied with symptoms such as palpitations, dizziness, and shortness of breath. So to diagnose POTS specifically, and even inappropriate tachycardia syndrome, either a 10-minute standing test can be used or a tilt table test. But we've We focused on the 10-minute standing test because it can be done in the office, does not require specialized equipment, and because of also the evidence that's available. But just keep in mind that the tilt test can be useful for individuals who, for example, cannot stand up. What does it involve? Briefly, basically, after a patient's been lying down for at least 10 minutes, they then must stand for 10 minutes, and there's measurements of heart rate and blood pressure at 1, 3, 5, and 10 minutes in the standing position. And I've listed here the criteria for making a diagnosis of POTS. So specifically an increase in heart rate of more than 30 beats per minute within the 10-minute period, without significant orthostatic hypotension, but there could be symptoms, of course, of orthostatic intolerance. And generally, we expect that the duration of these symptoms would have been going on for 3 months, and no other condition could explain the sinus tachycardia. So the CAN-PCC collaborative did suggest using the 10-minute standing test versus not using it in adults with suspected PCC and dizziness. Again, conditional recommendation, very low certainty of evidence. Next is the use of a questionnaire to screen for post-exertional malaise. So we talked about this as well. A post-exertional malaise or post-exertional symptom exacerbation is really a worsening of baseline symptoms or a really extreme fatigue or difficulty functioning after an activity. The activity can be one that's mentally, physically, or emotionally like exerting. And it can happen immediately after or really hours later, sometimes even a day or two later. And the malaise can go anywhere from lasting hours to also days, sometimes even weeks. So this is significant and something that's important, to consider. So ways that we can screen for it is by using tools. So there are like screening questions, for example, from the US Myalgic Encephalomyelitis Chronic Fatigue Syndrome Clinician Coalition. But there's also several, the PAL symptom questionnaire. So there's a lot of DSQ questionnaires. The one that we focused on for this recommendation was the DSQ PEM short form, because despite searching for evidence for all of the DSQ questionnaires, really, and even other forms of questionnaires, the evidence that was available was really for the DSQ PEM short form. So again, it's a hallmark feature myalgic encephalitis. Lots of patients with PCC have fatigue, and a considerable proportion of these individuals will have PEMs. So this is why this was considered to be important. And finally, the CAN-PCC collaborative suggests using questionnaires to screen for post-exertional malaise over not using them in patients with suspected PCC. So now we're getting into the recommendations that have been sent for public feedback, and therefore this is why we're discussing them today. But again, these are not the final versions. They may evolve or change a little bit. So as we've already discussed, a lot of patients with PCC have cardiac or respiratory complaints, and we go into a little bit more the exact prevalence numbers for breathlessness, shortness of breath on rest or on exertion, cough, and chest pain in hospitalized versus non-hospitalized individuals, meaning in the acute phase of their infection, of their COVID-19 infection. And I'm bringing that up because that's an important feature of this recommendation. The evidence does suggest that hospitalization related to severe acute infection does increase your risk of long-term pulmonary complications, and a lot of the data here that we could find related to chest X-ray for patients with PCC really related to individuals who were hospitalized in the acute phase of their infection. This is a recommendation still in process, so this is why our how we looked at the different domains is depicted this way because it's not in its final form. And right now what we have is a dual recommendation. Again, this may change, but the bottom line is that the chest X-ray is recommended in adults with suspected PCC and cardiac or pulmonary symptoms who were hospitalized due to severe COVID-19 infection in the acute phase of their infection. So we felt that this is where there would be more likely, the pretest probability is more likely to be elevated in this context. The next recommendation is on the chest CT. Here, I just want to point out that we used a regular non-contrast CT chest. And as we know, this can help us diagnose lots of different issues, both in the airway and in the lung parenchyma. Of course, the gold standard to look at the lung parenchyma is high resolution, non-contrast CT, but we focused on the regular due to it being more likely to be available across different communities across the country. So here, the main point to consider is, and this is what the panel considered a lot when evaluating the evidence for this recommendation and going through all the domains, was whether or not individuals were at high risk of having pulmonary complications. So high risk means it was defined as people with current respiratory symptoms and previously identified important abnormalities on chest X-ray or CT chest or pulmonary function tests, or patients who were previously hospitalized during the acute phase of their COVID-19 infection with a high clinical suspicion of pulmonary disease. This is what our summary of the judgments for the domains looked like. And in essence, we have, again, a dual recommendation. So the first recommendation is to not use CT chest in adults with suspected PCC and respiratory symptoms who are at low risk of pulmonary complications, again, using the definition that I just presented to you previously. And the second recommendation is using a CT chest in adults with suspected PCC and respiratory symptoms who are at high risk of pulmonary complications. Again, it's a conditional recommendation with very low certainty of evidence. And this is the recommendation in French. Given that, as you can glean from the number of symptoms, the potential severity of the symptoms that have been, and complications associated with PCC, we know that there is often an impact, right, on quality of life and functional status. And this is where we came up with the functional status, the use of tools to evaluate functional status and quality of life, and a recommendation on this. So based on what's most frequently used and what data was available, we focused on the Euroqual, so EQ5D, and its subcomponent, which is the EQ visual analog scale for the evaluation of quality of life, and the post-COVID-19 functional status scale to evaluate functional status. And this is despite the fact that the PCFS has not been validated specifically, but it has really been widely used due to its focus on PCC. So just as a quick recap, so the EQ5D is a score system that looks at 5 different dimensions. So mobility, self-care, usual activities, pain, discomfort, anxiety, depression. And the patient will fill out a level of perceived problem using a score from 1 to 5. And there's also the visual analog scale that goes with that. And the post-COVID functional status scale uses a scale rate between 0 to 4, with often a score of 3 to 4 showing limitations or severe limitations in everyday activity, which can lead to a referral to physiotherapy, for example. So our recommendation here is that the CAN-PCC collaborative suggests the use of tools. And here we evaluated, as I mentioned, the Euroqual and the PCFS to evaluate adults with suspected PCC and dizziness and or fatigue. Again, a conditional recommendation with very low certainty of evidence. Next, we had a recommendation for use of the CRP or C-reactive protein. So we know that it's elevated markers of systemic inflammation, such as the CRP, have been associated with different conditions, including infection, chronic inflammatory conditions, malignancy, autoimmune diseases. And so, there was a question as to whether, this could be important in the context of individuals with suspected PCC. So based on our evaluation of all the domains that we've previously discussed, the recommendation is to not order a CRP in adults with suspected PCC. This is a conditional recommendation, again, with very low certainty of evidence. Now, This is largely because of the test being not very specific. It can be elevated, therefore, in other conditions, and maybe can be useful if associated with other tests. And that's what we point out in our remarks, that it can be used in a specific subgroup of people with suspected PCC. For example, in individuals where there's symptoms that could be consistent with an autoimmune condition, or maybe patients who are presenting with symptoms associated with pericarditis. But of course, in all these situations, there's a need for additional diagnostic tests. Next recommendation is on ambulatory oximetry. So here we're specifically referring to performing a 6-minute walk test while monitoring SpO2. So with oximetry. And so, of course, during a 6-minute walk test, individuals have to walk at their baseline pace for up to 6 minutes without any additional encouragement, and basically, according to the way this test has been validated in the ATS guidelines, for example. And what's important here is really the SpO2 nadir during the test, the distance walked, and the maximal heart rate. So it's an interesting test because it could really reveal abnormalities really on exertion. It's in a sense has some similarities to like a stress test, right? A cardiac stress test. And when conducted in a standardized fashion, understanding the strengths and limitation of the test and being properly interpreted, it was considered that it could be valuable and should be considered. And some of the things that this could help uncover, for example, or can increase our suspicion to then pursue further investigation for entities like interstitial lung disease, a chronic pulmonary embolism, or pulmonary hypertension. It can also be helpful to just look at even exercise tolerance. So here, we wind up with 2 recommendations. Again, this is still not finalized yet. And really, the determining factor between one recommendation or the other has a lot to do with the risk of the 6-minute walk test component triggering post-exertional malaise or post-exertional symptom exacerbation. So in this sense, the first recommendation was for adults with suspected PCC and cardiac or respiratory symptoms who place a higher value on identifying potential hypoxia with exertion over the risk of PAM and or cardiac or respiratory symptom exacerbation. The CAN-PCC collaborative does suggest using ambulatory oximetry. Conditional recommendation, very low certainty of evidence. But in the situation where the risk of PEM is high, and this could be concerning, and and this sort of outweighs the value placed on potentially like identifying an underlying cardiac or pulmonary abnormality, then the recommendation is against it. But that being said, okay, we want to point out that if there are risk factors for a patient having really a high likelihood of having exertional desaturation, even with the risk of PEM, this should be discussed in detail, and really the pros and cons should be discussed with the patient so that they really do understand that there could be really a benefit of doing this test that could diagnose an important comorbidity at the expense of maybe a PEM, which could be a temporary discomfort. So again, it's a discussion to have with the patient. So, in summary, the baseline evaluation of people with confirmed or suspected PCC has, I'm sure a lot of you are already doing, it generally includes a targeted history and physical exam. And to that, there should be inclusion of regular and orthostatic vital signs. I think that's sensible. With other testing typically guided by symptoms, pre-existing or new onset comorbidities, and clinical indications. But this is a scenario where evidence-based recommendations, such as the ones that are being developed with CAN-PCC, can certainly help guide healthcare professionals in their selection of tests that can either increase suspicion of PCC or PCC-associated conditions or other comorbidities. And so today we've presented you a large proportion of these recommendations, but more will be coming out. And we hope that they'll be useful in your decision-making for further testing. So in terms of real quick, future directions and research priorities, So, of course, we would like more longitudinal studies in individuals who are hospitalized versus not in their acute infection, and longitudinal studies in individuals from understudied populations, such as those mentioned below, and evaluation of PEM and post-exertional symptom exacerbation risk and test acceptability in people with PCC and as it relates to different sorts of tests that are available. Of course, we're interested also in the impact of repeated infection, vaccination, different SARS-CoV-2 strains on the prevalence of symptoms and findings in certain tests. And of course, the discovery and validation of new biomarkers. So there's a lot of interesting tests that healthcare professionals, investigators, and patients alike are quite interested in, but are still in the research realm. And it would be interesting if we can get them out of the research realm and onto clinical practice. So I thank you very much for your attention.
Thank you very much, Dr. Falcone and Dr. Mustafa. We do have one question or conversation that's been going on in the chat around the DSQ-SF versus the DSQ-PEM and PEM screening. In addition to that, why I direct attention there, I will also invite anyone who has questions to please post your questions in the chat. You're also welcome to raise a hand so that we can select you for unmuting. The comment is from Anne. There is also the DSQ-SF, so DSQ short form, which is a 14-question questionnaire to screen for myalgic encephalomyelitis, and the DSQ-SF is not a screener for PEM. Unfortunately, DSQ-SF and DSQ-PEM are often confused. The DSQ-PEM is very useful, but its purpose when validated was not to screen for PEM in general, but discriminate between potential PEMs versus ME versus multiple sclerosis and post-polio symptom. Therefore, in clinical settings, it's important to also use the history to screen for PEM, and then there was some additional information there. So it's more of a kind of a comment, but if you wanted to comment on the DSQ-SF versus DSQ-PEM.
Yeah. So thank you, Anne, for that question. So of course, yes, and if individuals want to come and look in more detail on the Paul site, there is really a long list of questionnaires that have been developed, and several, you're correct, have used the DSQ short form. Our selection of the DSQ-PEM was really based on available evidence. And since that's where the evidence lies, that's what we had to focus on.
Yeah, and to just kind of complement what Dr. Falcone just said, we actually were intending to collect the evidence on any of these tools if it existed. But unfortunately, it didn't. And it adds even more complexity and great point that even the tools that were developed specifically for PEM, like the SQ-PEM, were not, as you very appropriately state, validated to screen for PEM. It's to distinguish different things, right? But this is the best we have. And so I hope many of you and others who have interest in this area will do more work on validating some of these important tools.
Absolutely. Thank you for that. Yeah.
And I'm just going to invite Anne to unmute and just join the conversation to explain her question a little bit further.
Yes, I totally understand that you did not use the DSQ short form. One of the reasons I put the comment is because since sometimes the DSQ-PEM is called the DSQ-PEM short form, in some studies and papers, the DSQ short form, which is to screen for ME, has been confused with that DSQ-PEM. So I just wanted to, explain people who are less familiar with PEM to be careful and mindful of differentiating the two tests because they're intended to do different things.
Excellent point. Absolutely, because you're correct. It could be confusing and mislabeled because of the term short form being included also be after the DSQ-PEM. It's really the DSQ-PEM short form. So very, very good point, and points towards how this could impact a review of the evidence and has to be considered. So something that we've discussed. So I am certain was done, but we can always relook and we can always, search more. Of course, it's a very important point.
Thank you very much, Anne. We also had a comment from in the Q&A, and it was just curious about just the role of nurse practitioners and also physician assistants in providing services for clients with long COVID or post-COVID condition. And there's just that kind of, in the slides, it was noted earlier that there was messages to physicians, but just maybe if you can expand on the role of NPs, and I know they've also been involved in selecting the guidelines as well.
I'll start addressing that. Really, everything we are talking about in these guidelines are intended and meant for healthcare providers in general. There was one slide, and I believe I was quite cautious of, and language sensitive into that. But there was one slide when we talked about the implications of strong and weak or conditional recommendation that was labeled as physicians. And this is something we'll bring back to the attention of the CAN-PCC initiative, just to relabel that slide. But everything we said does 100% apply to healthcare provider in general. Actually, we had quite a bit of discussion about the importance because we want people to have access to care, and we want people to have access to tests when appropriate to get them. So I hope that clarification will solve the issue. I don't know, Liana, or if you want to add anything to that.
Yeah, thank you, Dr. Mustafa. So indeed, one thing that's evident with the care of people with post-COVID condition is that this is a multidisciplinary effort and the whole team is involved. So anyone, all of the individuals involved in healthcare play a role, from nurses, nurse practitioners, yes, physicians, physiotherapists, occupational therapists. I can go on and on. So that's absolutely certain, and these individuals play a role in the management, in the evaluation, and follow-up. So of course, the intent is to be inclusive in the language, and I would say that even the panel members reflect also, to a certain extent, the range of individuals across the levels of care and the spectrum of care that's provided to individuals with PCC.
And thank you very much. So what I'm going to just do is the quick announcements. Please note the Q&A is still open, so if you have additional questions, please put them in the chat or let us know. Just a reminder, and I wanted to first say thank you to everyone who's attending today. We also wanted to just provide the information around the next steps for this. So I'll just do this shortly, and then we'll come back to any further questions. So just a reminder for resources for patients, there is the Guide, which is previously called the Long COVID Guide. And there's also the interactive infographics and online resource sheets and webinars that are available through CAN-PCC. There's also resources for health professionals, including these webinars, as well as an online course that's under development. And then we also have the Connect Canada. And I want to say thank you for attending, and that there is a survey. And if you happen to need to scan a code, the code is on the screen, and the link is in the chat. And staying up to date is the CAN-PCC website, and you can check out the recommendations map and the QR code. And I want to send again tremendous thank you to all of those who've been involved. And if you would like to register for more webinars, particularly the ones that are hosted from CAN-PCC, but hosted by the University of Saskatchewan, please look here, as well as the webinars that are directly hosted by CAN-PCC. So just returning to the questions. Any further questions today? Well, I want to say that oftentimes when there's no questions, it means that you've done a tremendous job with the presentation. And thank you again for presenting. And thank you everyone who is here today and for your comments and questions. We appreciate it, and have a wonderful day. Thank you.